I'm Dr. Tushar Arora. I'm a practicing neurosurgeon and I have been practicing neurosurgery for the last 16 years. I was trained at All India Institute of Medical Sciences. Now today I'm going to talk about epilepsy and especially its surgical management. According to WHO, epilepsy is one of the most common serious brain disorders that affects all ages and classes. There are 5 crore people with epilepsy worldwide, and out of those 50 lakhs to 1 crore reside in India itself. So when we say intractable epilepsy, how do we define intractable epilepsy? Like, when do we start saying that the patient is having intractable epilepsy? So the rule is 2-2-2. That means 2 seizures every month for 2 consecutive years, despite taking 2 or more anti-epileptic drugs in maximum tolerated dose. If all these 3 criteria are met, we can label the patient as intractable epilepsy. And 1/3 of all patients of epilepsy ultimately turn out to be intractable epilepsy, and they're all potential surgical candidates. They should ideally be evaluated properly and they should be selected in case they turn out to be candidates for surgery. And even in India, it is calculated that around 10 lakh patients of medical refractory epilepsy are potential surgical candidates and would benefit if undergo epilepsy surgery. Now, uncontrolled epilepsy also causes progressive disability and is considered to be having an increased risk of mortality also. And the purpose of evaluation by a surgeon for an epilepsy surgery case requires that there should be a definite demonstration that the seizure originates from a region that can be removed with minimal risk of disabling neurological or cognitive dysfunction. That means surgery is done when we feel that the lesion can be safely removed without causing any definite harm to the patient. But after confirming that the lesion that we are seeing is the actual culprit, is the epileptogenic zone for that particular case, and each case has to be individualized. Now, if we divide such cases who are considered for surgery, and the epilepsies which are included, we can divide them as mesial temporal lobe epilepsy and neocortical epilepsy. So mesial temporal lobe epilepsy is definitely the more common variety, with a much higher success rate after surgery as compared to neocortical epilepsy. And there are definite lesions which are associated, like low-grade neoplasms like gangliogliomas, DNETs, low-grade astrocytomas, oligodendrogliomas. All these lesions, if they are proven to be the cause of epilepsy, then the aim would be to completely remove such lesions and also the surrounding epileptogenic brain matter, which will ensure a seizure-free patient after surgery. Now, apart from tumors, there are definite developmental abnormalities which can also lead to intractable epilepsy. Like, we have focal cortical dysplasias, type 1, type 2, and type 2 is considered to be more related to intractable epilepsy. Tuberous sclerosis, Sturge-Weber syndrome, leptomeningeal venous angiomas, hypothalamic hematomas, epilepsy due to vascular malformations. So these are the cases where the surgeon is in a better situation to help the patient, because once the evaluation has been done and it has been proven beyond doubt that the lesion is the culprit, is the cause of epilepsy, so this surgery would definitely benefit such patients. So just narrating the pre-surgical steps of evaluation, the main goal is identification of the epileptogenic zone, which includes that area which is generating the patient's seizures, and also the region which is surrounding it, which is considered to be as a potential epileptogenic area. And the gold standard is surgical localization is intractable epilepsy for such patients is a ictal EEG pattern identified by long-term scalp recordings, which we call as a video EEG monitoring. Patient is kept in the EEG lab for a definite period of time, and the semiology and the EEG findings, they are correlated, and once there is correlation, then that is one of the steps which will guide the surgeon towards selecting the patient for a surgical procedure. And the second is neuroimaging. Of course, neuroimaging, if it shows clearly focal lesions like tumors, cortical dysplasias, areas of gliosis, neuronal loss with atrophy, development abnormalities, and if all these investigations and neuroimaging, the EEG, they are correlating with each other, with the clinical presentation, with the clinical semiology of the patient, then the surgery is definitely going to benefit the patient, and the patient is advised surgery. Of course, the ultimate decision of whether the patient undergoes surgery or not lies with the patient and the family, and I think it is at that stage that most of the patients do not agree or maybe are afraid of surgery. So this is what we have to encourage and teach people about the benefits of surgery and the overall improvement in the quality of life of the patient. So temporal lobe epilepsy is the most frequent form of such refractory epilepsies, and it also has the best prognosis. And MTS, that is medial temporal sclerosis, in young adults is one of the most common causes. Initially, such cases may be controlled with drugs, but subsequently, over a period of 1 to 15 years, the seizures become gradually more difficult to control, and it is then that surgery would be considered and would definitely be proven to be beneficial to the patient. Now, the burden of epilepsy in India is definitely being reduced by efforts, but still poverty, lack of education, lack of resources, lack of education, all these things definitely would go a long way. If we are able to overcome such problems, if we are able to overcome, then definitely it is going to go a long way in empowering our epilepsy surgery system. So in conclusion, the burden of epilepsy in India could be reduced by alleviating poverty, by reducing the preventable causes like perinatal insults, parasitic diseases, head injuries, empowering primary healthcare workers to diagnose and start treatment might significantly reduce the treatment gap and the disparities between rural and urban areas. And as a neurosurgeon, I can only say that in view of the large discrepancy between the number of potential cases for surgery that we have, around 10 lakhs, and the number of surgeries that are being actually done in India, this gap has to be gradually reduced, and more cases have to be encouraged, and more epilepsy surgery centers have to be developed all over India. And this is a wish, and we hope that we'll be able to achieve at least part of this goal. Thank you. Thank you very much for listening.